Well, thank you for your attention this afternoon, and I will be speaking on salivary gland ultrasound. I have no disclosures. I'll begin with this somewhat problematic case. This was a 48-year-old healthy woman who came in for a lump under her chin, which ended up being a very unexciting lymph node, but had this incidental finding in her right parotid. Just under a centimeter, looks almost cystic, very well circumscribed, but we put color on. It had internal blood flow, and therefore it was presumed to be solid. It was biopsied. And very unfortunately for her, this was adenoid cystic carcinoma, which, as we'll describe later, has a fairly bad prognosis. And this highlights some of the challenges of salivary gland ultrasound. Before I get into more of the sonographic findings, I'm going to, review a little bit of anatomy. Parotid gland anatomy, I think, is tough because there's a lot of stuff that is near it and runs through it, particularly the facial nerve, which goes through the parotid gland and divides the gland anatomically and surgically into superficial and deep portions. We usually cannot see the facial nerve, but we can often see the retromandibular vein, and that's a good imaging marker for the facial nerve because the nerve is just lateral to the retromandibular vein in most cases. The external carotid artery goes into the gland, terminates in the gland, giving its final branches, including the internal maxillary. The distal ICA is not in the gland, but it is in the neighborhood. It's just deep to it. The parotid gland is drained by Stinson's duct, which comes anteriorly to drain into the side of the mouth. And most parotid glands contain lymph nodes, on average about 10 lymph nodes per gland, and almost all of which are in the superficial portion. And here's just an example of a normal intraparotid lymph node. So some pictures to illustrate this anatomy. On CT, here is the retromandibular vein. On a corresponding ultrasound, this is the parotid tissue. Here is the mandible, the masseter, and the retromandibular vein. The external carotid artery can often be seen right next to the retromandibular vein. Here in this Doppler cine, this is the retromandibular vein heading inferiorly, and just deep to it, the distal aspect of the external carotid artery. In the neighborhood, just deep to that, the internal carotid artery, the internal jugular vein, and actually fairly close in some patients, the vertebral artery, which can actually come into play with some biopsies. I just have to watch for that. The facial nerve, the dreaded thing for our biopsies. We can't usually see it with ultrasound. Occasionally, if MR works exceedingly well, we can see it just below the stylomastoid foramen. And here is where it is coming into the parotid. And this is the rough course that it takes. Of course, this is a three-dimensional structure, so it is arborizing the the pes as it goes through the parotid towards the masseter muscle. So it goes up to down quite a bit, but this is the rough course that it takes, the plane of the vein. So superficial this, superficial parotid, deep to this, the deep parotid. Now I said we can't see this on ultrasound. That's most of the time. This is an unfortunate case of a relatively young man who had a horribly aggressive squamous cell carcinoma of the mid-face that presented with neurological symptoms, and all of this linear hypoechogenicity are branches of the facial nerve coming anteriorly towards the masseter. And the retromandibular vein can also be used to sort out if you're not sure if something's superficial or deep. This pleomorphic adenoma is superficial to the retromandibular vein, therefore it's superficial. And another example of a pleomorphic adenoma, this time deep to the retromandibular vein, so in the deep portion. Submandibular gland anatomy is a little bit simpler. The submandibular gland, as you know, is in the level 1B submandibular fossa, and it is between the mandible and the mylohyoid muscle. It is drained by Wharton's duct, which heads posteriorly and then superiorly to drain right next to the sublingual gland. This is anti-gravity drainage, assuming that you're upright, which is important probably in stone formation. There are a lot of lymph nodes near the submandibular gland, but usually not in the submandibular gland. One of the things we see with imaging that I'm not going to cover in great detail, but we certainly see, is inflammation. and that can be divided into acute or chronic. Acute can often be viral, it can be bilateral. Bacterial certainly occurs, can be unilateral, such as in this case, where you see the left parotid is expanded, hypervascular, heterogeneous as compared with the left parotid. If this gets really bad, it can end up resulting in an abscess, such as this interparotid abscess. And with abscess in almost any part superficial, a little bit of gentle pressure and release of pressure can help to confirm that there's mobile debris inside of it. Chronic inflammation can be obstructive, fairly commonly due to stones, or non-obstructive due to a lot of causes, including autoimmune disease. Stone disease, silothiasis. The vast majority of this occurs in the submandibular gland or in Wharton's duct. One of the reasons is likely the anti-gravity drainage of Wharton's duct, less common in the parotid. These stones are often not seen on conventional radiographs, can usually be seen on CT. It's said it's important to determine if it's in the gland or at the margin or just outside the gland. And sometimes stones in Wharton's duct can be confused for material debris in the floor of the mouth. Here is just a cine seeing this stone here. I thought it was probably a stone, but I did what's been suggested and just put a gloved finger into the mouth to just confirm that that is a stone with general ballottement. And actually, I got the stone right out, which wasn't what I was expecting. The patient was extremely happy, and here's what it looked like after the stone is removed. The submandibular gland was still inflamed with some dilated ducts, but the patient actually felt better almost immediately. He was actually referred for a biopsy of the submandibular mass, which obviously didn't happen. Sjogren's syndrome, most common autoimmune condition you're going to see in the salivary glands, involves the major and the minor salivary glands. It can be primary or secondary. These are the autoantibodies that are often seen, as well as rheumatoid factor. And you get a heterogeneous sonographic appearance of the salivary glands with areas of hypoechoic foci that can be rounded with some intermixed hyperechoic linear bands. To some extent, it kind of looks like Hashimoto's of the parotid, although it may not be nearly as diffuse. It may be a little bit more patchy. And there actually, if you are in a situation where you have a lot of rheumatology, there actually are some staging schemes that have been proposed and are in clinical use for both diagnosis and monitoring of therapy in Sjogren's syndrome. One thing important to know about Sjogren's syndrome is that these patients do have a risk of developing lymphoma, often a MALT-type lymphoma. 5 to 10% of patients with Sjogren's may develop lymphoma within 15 years of diagnosis. Here's a case of bilateral lymphoma. So any confluent large mass in the setting of Sjogren's should be biopsied with testing as appropriate for lymphoma. You can get simple cysts in the salivary glands, particularly the parotid. You're not going to biopsy something like this in the thyroid. In the parotid glands, not uncommonly, we will aspirate these just to make sure that it is a simple cyst. If there's no solid component, you can completely aspirate it, and there are no worrisome cells in the aspirate. You can say this is a benign lesion, even if the cytopathology is technically non-diagnostic, but the radiology report saying it was completely aspirated with no solid component is necessary for that. In HIV disease, occasionally you can see this entity, multiple benign lymphoepithelial lesions within the parotid glands. Okay, salivary gland pathology. Several good factoids here. 70% of things that clinically present as masses in the parotid are neoplasms. The risk of malignancy for a salivary neoplasm is inversely proportional to the size of the gland. 20 to 25% of parotid neoplasms are malignant. 50% of submandibular gland neoplasms are malignant, and 75% of the rare sublingual gland neoplasms are malignant. 70% of salivary malignancies, however, occur in the parotid, and that is because parotid tumors are way more common than tumors in the smaller salivary glands. 80-90% of parotid tumors arise in the superficial lobe. The WHO classification includes, and I'm not kidding here, 28 different histologic types of primary salivary malignancy. In the thyroid, it's basically 4, maybe 5. And many of the salivary primary tumors have low, intermediate, and high-grade variants. It has been described as the most heterogeneous of any group of cancers in the human body, which makes a real pathologic challenge, particularly with fine needle aspiration. And there is overall 5-year survival with primary salivary cancer. There also are at least a dozen primary benign lesions of the salivary glands. I'm going to just go through the most common primary salivary benign and malignant lesions. The most common benign lesion, actually the most common lesion in general in the salivary glands, is the pleomorphic adenoma. It is usually solitary. 80% occur in superficial parotid, 10% in the deep parotid, and then the rest in the other salivary glands. It is composed of epithelial, myoepithelial, and mesenchymal tissue, thus the pleomorphic adenoma. Typically hypoechoic solid mass with lobulated borders, that's kind of classic, may have calcifications, occasionally some cystic change, often not that vascular. What is important to know, though, is this is potentially a pre-malignant lesion with reported up to 5% chance of converting over to the dark side and becoming a carcinoma ex pleomorphic, which has a fairly grim 40% 5-year survival. And here is an example of a carcinoma ex pleomorphic. It is solid, lobulated with some calcification, a little bit of internal cystic change. It's pretty bizarre on CT and a lot of heterogeneous low signal on T2 MR, concerning but certainly not specific. The other common benign tumor is a Warthin's tumor. The old term for that is cystadenolymphoma, which I think has largely been abandoned because it sounds like it's a malignancy, and it's not. It's benign. These almost always occur in the parotid. So I do harass my residents when they include it in a differential for a submandibular mass because it probably shouldn't be in that differential. It also has an extremely strong association with smoking. Does not have to be active smoking, but usually occurs in people who either are or were committed smokers. It contains epithelial and lymphatic tissue. It may have cystic components. They tend to be fairly vascular, but not always. And this is a benign lesion. Malignant transformation is rare if it ever occurs. When I polled our pathologists at OU, they feel that this does not have a malignant potential. The most common malignancy in the salivary glands is the mucoepidermoid carcinoma. It is composed of mucus-secreting intermediate and epidermoid or squamous cells, thus the mucoepidermoid carcinoma. This has low, intermediate, and high-grade histology variants, which have very discordant clinical behavior, from a fairly indolent 75 to 89% 5-year survival to a less than 50% 5-year survival for the high grade. They may have cystic components such as this one and this one. The high-grade tumors often are very ill-defined infiltrative, but the low-grade and small tumors can be very well-defined and honestly overlap with benign lesions. The second most common malignancy of the salivary glands is the adenoid cystic carcinoma. It is considered an intermediate grade tumor. It is indolent, yet often highly fatal. That may seem confusing. What that means, it is a slow-moving tumor, but it is a problem. And unfortunately, this case in that young woman, hopefully she will be one of the few that is cured. But it has a 35 to 70% 5-year survival, but only a 10 to 20% 10-year disease-free survival, and no better than a 50% 20-year survival. Late, distant metastases and local recurrence with perineural invasion, unfortunately, is common. Has a variable appearance on imaging. It's been reported in the literature as having a lot of color Doppler signal. Honestly, I have not found that to be consistent in the cases I have seen. Potentially the third most common salivary malignancy, primary salivary malignancy, is actinic cell carcinoma. It's a low-grade malignancy. It's actually previously was regarded as a benign lesion. It has an unpredictable behavior, but overall a very good 5-year survival. The other thing to consider is that metastases to the parotid are fairly common because there are lymph nodes in the parotid, and those parotid lymph nodes are the primary drainage for a lot of the skin, of the mid-face, the ear, a lot of the scalp. And so skin cancers metastatic to the parotid, at least in our head and neck practice at OU, are really common. Almost every week at Tumor Board, we discuss at least one. And here are some examples: squamous cell carcinoma, basal cell carcinoma, melanoma, and Merkel cell carcinoma. So all of the major skin cancers that are seen predominantly in an elderly population. You can also occasionally get distant metastases to the parotid. Here is an example of a very hypervascular solid lesion, which was a distant met from renal cell carcinoma. This was interesting to biopsy. And then you can see it also from lung cancer, such as this case, breast cancer, and others. Okay, so a very important question in my opinion. Can ultrasound determine if a parotid mass is benign or malignant? You've heard earlier today some really great talks about risk stratifying thyroid nodules. Does any of that apply to the salivary glands, specifically to the parotid, since that's where most of these tumors occur? Well, before I answer the question, I'm going to give you a try. So I'm going to show you a number of cases. One is benign, one is malignant. Nobody's really guessing. Well, this is a pleomorphic adenoma. This is a high-grade adenoid cystic carcinoma, a very bad lesion. The only difference really, and it's subtle, is that this one is wrapping around the retromandibular vein. But otherwise, I think these look about identical. Okay, so, well, that was hard. How about another one? So this is a mucoepidermoid carcinoma. This is a pleomorphic adenoma. Well, how about this one? Which lesion is malignant? I think they look pretty similar, except this one is more vascular, and it's benign. It's a Warthin's tumor. This was a high-grade mucoepidermoid carcinoma. And these two, they look, I think, almost identical. They are honestly different patients. This one has a little bit more blood flow. It was a Warthin's tumor. This was metastatic squamous cell carcinoma in an intraparotid lymph node. Okay, one more. Some fairly circumscribed, well-defined hypoechoic solid lesions. This one may have a touch of calcification. And it's a high-grade salivary ductal carcinoma, a very aggressive tumor that has some similarities with breast cancer. This was a benign pleomorphic adenoma. Okay, so I think you might be able to guess where I stand on this question based on the cases I've shown you. The biggest article in the literature to actually address this question was from 1989, and they found 272 of 302 cases of parotid lesions were correctly identified as malignant or benign. But there's a couple of big buts about this. One is that unsharp border was the only sign of malignancy, and in this case, 28% of malignancies had a sharp border, and they were called benign. I don't think this is good because, in my opinion, it may be those benign-looking malignancies that have the greatest chance for cure of what can be a very aggressive lesion. And the other thing is, if you call everything in the parotid benign, you're going to be right about 80% of the time. More recent articles, including at least one that looked at contrast ultrasound, have mostly concluded that ultrasound cannot correctly classify lesions, but they're limited by small numbers of malignant lesions because most parotid tumors are benign. So what are malignant features? An irregular or infiltrative margin, encasement of the retromandibular vein or external carotid artery, local adenopathy, which is usually level 2 or level 3, but that's rare, and encasement of the vein is rare as well. Rapid growth, if you get that clinical history. And here, this is probably the most important one and possibly a SAM question. Neural symptoms. If somebody has pain or even worse, a slowly developing ipsilateral facial droop. That's really worrisome because benign things usually don't take out the nerves. Unfortunately, many malignancies have none of these features. I'm going to describe just a few other pitfalls in parotid mass imaging. One of them is that the parotid is it's kind of like the kidney, produces wonderful opportunities to make stuff up that does not exist. And here is an example. This kind of looks like a real lesion, and as I've described, we'd be having to biopsy this. However, when you really looked at it and turned in an oblique plane, you saw this was continuous with the adjacent fat, as was shown on real-time Cine imaging. It actually, this CT isn't great because of artifact, but it's this little bit of interdigitated adipose tissue, because the parotid can kind of have little fingers to it. And so this is a common pitfall. It's easy to fall into this. We probably have this issue maybe once a week in our lab. We do a lot of head and neck ultrasound, but it's a common issue. Another really problematic issue is not finding stuff deep enough in the parotid. This was a relatively young woman, had an MR for a headache, didn't show anything in the brain, but showed this bright T2 lesion in the deep margin of the parotid, probably a pleomorphic adenoma, but appropriate for biopsy. She came for biopsy, and the initial sonographer images, there's no lesion. She found this benign-looking lymph node, which corresponds to this, but was not looking deep enough. So using a lower frequency, looking deep enough, knowing where to look, we see this lesion, which was biopsied and proven to be pleomorphic adenoma. The last thing is failure to visualize the deep aspect of a deep mass. So this looks like a circumscribed, lobulated, solid hypoechoic mass, not specific, but good for a pleomorphic adenoma. And it looks like you're seeing the whole thing. I want to thank Dr. Tifi for this amazingly beautiful image of an iceberg. And here, you're not seeing the whole thing. Well, let's look at this on MR. This is what we saw with ultrasound. This is just a little extra bit of it that might affect patient management. And actually, it was subtle on the PET CT. We were really worried about a carcinoma ex pleomorphic, and the biopsy was suspicious as well when I performed it. But fortunately for the patient, it ended up being just a very cellular pleomorphic adenoma at excision. We're going to watch it really closely because we're still concerned about it. So the moral of that story is that deep lobe parotid lesions, as much as I love ultrasound, they need MR or CT because you can miss something. It's difficult to see everything, and you don't want the patient to be managed inappropriately. So lastly, I'm just going to briefly cover biopsy. So why should we biopsy salivary masses? Why not just cut them all out? Well, that's a great question, and I've kind of talked to some surgeons about this at times. And one of the easy answers is that some of the masses are not treated surgically, like Warthin's, lymphoma, malignancies that are not resectable, non-neoplastic lesions, and some metastases. But even if surgical excision is planned, pre-op diagnosis, surgeons will argue, is still helpful. Does this patient need surgery in 1 or 2 weeks because they got a cancer? Or can we do this, over Christmas break when it's convenient for the patient because it's a pleomorphic adenoma? And it allows for more accurate counseling of the patient regarding the prognosis and the likelihood of facial nerve injury or sacrifice. A generation ago, surgical incisional biopsy was performed. That is now considered contraindicated, not to be performed in the surgery community due to both the risk of nerve injury and the high risk of tumor seeding. So if we do a biopsy, do we FNA? Do we core? Do we do both? There are a lot of opinions. This has been studied actually quite a bit. And FNA has a long track record, great safety record. There's a lot of evidence for core biopsy, good safety record, and almost always has been shown to work better than fine needle aspiration. And some people have advocated that you shouldn't FNA these, you should just core them. That is actually not our approach at OU. Our approach is based on the fact that we have some really good cytopathology support. And we will almost always begin with fine needle aspiration. After a little bit of lidocaine, we generally try to traverse as little salivary tissue as possible. And then based on a real-time assessment by the cytopathologist in conjunction with the radiologist being familiar with the imaging and the history, we will decide, do we need to core it? Do we need to collect for flow cytometry, cultures, etc.? If we core it, we use 18-gauge semi-automatic adjustable throw side cut needles. Here are a couple of manufacturers that we use. We do not make an incision. Almost always it's single needle technique, very rarely coaxial. And what we do is we get in the lesion and then we manually deploy the whole cutting area, make sure it is completely in the lesion before firing the needle and cutting. And here's a movie of doing it. You can see getting in the lesion, deploying, it's good, so go ahead and cut. And these were both pleomorphic adenomas. If it's a mixed cystic solid, just like in the thyroid, you have to target the solid component. I did an FNA first, and the cytopathologist said, you got a few atypical cells, this is not going to be diagnostic, and so took a core biopsy of it, diagnosed a mucodermoid carcinoma. When we reviewed our experience with this FNA first, core if needed, that we recently published, over a 3-year period, 135 procedures, we only cored about 25% of patients, and we had a 93% diagnostic pathology, and as of yet have not identified any missed cancers in that group and had no significant complications. But again, I would say that I am blessed to work with some excellent cytopathologists, and this would only work if you have complete buy-in of excellent cytopathologists. Briefly, deep lobe parotid lesions. These can result in a little bit of adrenal and sphincter hyperactivity when they come for biopsy. Fortunately, they're uncommon. I think these, I like for them to go to our multidisciplinary head and neck tumor board before I biopsy them if possible, and they need MR or CT imaging to make sure that we're not missing something, that we're not getting fooled. But there are 3 approaches to deep lobe parotid if you have to biopsy them. One of them is to just say, you know, whatever, I'm just going to go right after it, go right through the parotid, knowing that unless you're really posterior, you will cross the plane of the nerve. Even if you do that, the safety profile is very good. You're going to make sure if you have to core it, your core is completely in the mass, not getting parotid on the way in. And the thought is if there is nerve in the mass, the nerve is hosed anyway, basically, is the thinking there. I don't like doing this if I can avoid it, but sometimes it's unavoidable. If it is a very posterior or inferior lesion, you can do a posterior-inferior approach. This is, you have to turn the patient, this is way posterior-inferior, going through the very origin of the sternocleidomastoid, and you can often get into something in this location without traversing any parotid and not crossing the plane of the nerve. I will say, though, the vertebral artery is not far away from this. So if I'm doing this approach, I find it and make sure I'm not going to stick it. The final approach for a more anterior superior lesion is, again, I love ultrasound, but I will occasionally switch over to a CT biopsy with a transfacial approach. This looks crazy, but I just snow them with plenty of conscious sedation. This is actually very well tolerated, just using a skinny needle FNA. Take-home points. Silolithiasis occurs mainly in the submandibular gland. Lymph nodes are a normal finding in the parotid. Evaluate them just like you would any other cervical lymph node. Masses with an infiltrative border are frequently, but not always, malignant. Some infectious and inflammatory conditions can look infiltrative. There is a substantial overlap in the ultrasound appearance of benign and malignant salivary masses. Masses in the deep lobe of the parotid need MR or CT imaging, and ultrasound-guided core biopsy of salivary masses is safe and improves diagnostic yield and sensitivity, although if you have great cytopathology support, it is reasonable to begin with FNA. So thank you for your attention.